Hello, a very good afternoon to everyone. Thank you for joining us today again for our eco session. You're welcome. Thank you for choosing this station this evening or this afternoon. Today we are discussing a very important topic that most of us may have encountered once in a while. Some we've heard about it. Some have read about it, but today we get a chance to get a scenario and a walkthrough some of the things that we shall see in the emergency department. So today we are discussing life-saving strategies for blasts and ballistic injuries. And with me, I have a team of great experts. Some are online, some are with us here physically. And without further ado, I'm going to ask each one to quickly introduce themselves. Firstly, I will go. I am Anna Mary Dakabuna. I'm an emergency physician working with Malago National Hospital. I'll be your moderator for the session. I think I'll start from my left, extreme left, coming to the right.
Right. Good afternoon, team. Jackson Kutagwa is my name. I'm from the Department of Nursing and UPDF. So I'll be doing the nursing part for our case management. Thank you.
Good afternoon, everyone. Priska Chizito. I'm an emergency physician in Bara University of Science and Technology. I also teach there and work with Bara Regional Referral Hospital, and I'm really glad to be here. Looking forward to the interaction with the rest of the audience.
Good afternoon, dear listeners. I'm Dr. Paul, emergency medicine resident, year 3, and I'll be your case presenter for today. Thank you.
Good afternoon, everyone. My name is Okirod Andrew. I am an EMT from the pre-hospital. Thank you.
Okay, thank you. And joining us online is Major Dr. Robert Oberpos. Kindly unmute and introduce yourself.
Yes, good afternoon, colleagues. As she has introduced my name, by that names, I'm speaking from the Horn of Africa, that is Somalia, Mogadishu, where I am, level 2 hospital under UN. Thank you. So I'm part of the panelists. Thank you for having me in this session.
Thank you too, Major. We are glad to have you and learn from your great expertise. To the team joining us online, just a few housekeeping rules. Kindly, when you join in, mute your microphone, turn your video off so that we do not get disrupted. And if you have any questions or any concerns, please post them in the chat or raise your hand up. You will be picked to raise your concern. Over the next 3 minutes, I would love to get a few concerns from the team or from the people online. What are your expectations from this session? When you heard that this Friday we are discussing ballistic injuries, what came to your mind? What would you want to learn from this session? You can post your comment in the chat, and then we will just choose a few, 2 or 3 people to give us their expectations. Anyone? You can raise your hand up. Anyone? If you have an expectation, please raise your hand up or post in the chat. Okay, so we have a few expectations coming in. Stephen Odoch would want to learn scene safety measures. Mulebo Joel, clinical approach to a patient with ballistic injuries. And then an interesting one, career opportunities in the field of emergency nursing. Red flags, workup and treatment approach, then commonest life-threatening injuries and their management. I think that applies to ballistic injuries. Okay, so thank you, everyone. Keep the comments coming in. We will start our case as of now. And I hope by the end of the session, we shall meet all these expectations. So presenting us with the case is Dr. Paul Sekate. Please take the floor.
Thank you, Dr. Anna. Welcome to our echo session today. I'm Dr. Paul, and I'll be taking you through the case. This is a case of Eke, 35-year-old male, a soldier, serving as a deminer while sweeping a suspected IED route ahead of a foot patrol in a high-risk major transport route, triggered unarmed personnel improvised explosive device. He was reportedly thrown into a trench about 6 meters away following a loud blast. Had brief loss of consciousness around 1 to 2 minutes, then woke up confused and screaming in pain, bleeding from both lower limbs, and the patient was also complaining of severe chest pain, shortness of breath, and inability to hear. A quick primary survey was done, and in the airway, he was speaking in short sentences, had soot visible around the mouth and the nares, and at that time, there was no stridor. The breathing, he was in marked respiratory distress with a respiratory rate of 32 breaths per minute, SpO2 of 86% on room air. The chest was asymmetrical with a tracheal deviation to the right. The left chest was hyperresonant with reduced air entry. The extremities were cold. He was diaphoretic with a cup refill time of more than 3 seconds. Heart rate of 130 beats per minute, blood pressure of 80 out of 52 millimeters of mercury. Heart sounds 1 and 2 are heard, and noted was bleeding from the amputated bilateral lower limbs, catastrophic bleeding from the bilateral amputated lower limbs. GCS of 14 out of 15, the pupils equal and reactive to light, approximately 3 millimeters, no focal neurological deficits, and the random blood sugar was 6.8 millimoles. On exposure, what was very significant was the bilateral traumatic lower limb amputation. With the right knee amputated, with the right limb amputated above knee, and the left knee amputated below knee. The pelvis was stable, multiple shrapnel wounds on the abdomen, upper limbs, and the thighs. Superficial flash burns to the face and hands, and bleeding from both ears with a temperature of 35.3. No step-off lesions along the vertebrae at that time.
So we've had an interesting case so far, and at this point, we want to launch a poll, which is going to run over the next 2 minutes. And from the history that we've had, what are the imminent emergencies in this patient? What are the imminent emergencies in this patient? Can see, we shall stop this poll when we've had at least 70% attempted. Okay. Okay, so majority of us have chosen option 3. In the next 5 seconds, we are going to end the poll. We're going to discuss this, the poll at the end of the session, so don't worry. Okay, we can end the poll now and move to the next session.
So from the history above, we look at the emergency conditions in this patient that have to be attended to in real time so that we can have this life saved. And the airway, we look at this patient with the history of soot around the mouth and near. This patient is at risk of inhalation burns, and the risk is airway obstruction. Breathing, he's in respiratory distress in view of the chest asymmetry, the respiratory rate of 32 breaths per minute, SpO2 of 86%, hyperresonance, and reduced air entry to the left. So the risk that we are worried about is attention pneumothorax, and which could lead to hypoxia and later a cardiac arrest. In circulation, because of the amputated lower limbs, due to the catastrophic bleeding, we are worried about the hypovolemic shock that could actually lead to death. Notably, one thing is that about this patient, the patrol team, the team that was following him applied the tourniquets on site immediately after the explosion.
Okay, so we have our second poll running. Interesting. So being launched soon. So what are the emergency life-saving interventions for this patient? We've had what were the emergent signs and presentations of this patient. Now I want to know, if you had the same patient, what would you have done? It may be listed or not listed. So just choose among the choices that are here. What are the emergency life-saving interventions for this patient? Again, I'll end this poll when we've had 70% of the team attempting. Okay, keep the answers coming in. We have now 47% attempt. What are the emergency life-saving interventions for this patient? Remember what the problems that Dr. Paul has listed for us. What are the emergency life-saving interventions that you would have done for this patient? Okay, keep the answers coming in. We are at 62%. Okay. I think we're going to end the poll. I don't see any more answers coming in. 130 of the 200 have answered, so we shall end the poll. Like I said before, this will be discussed later on. Dr. Paul, please continue.
So looking at the threats that we identified above, we had to intervene in real time. In the airway, this patient was at risk of inhalational burns or had inhalational burns in view of the visible soot around the mouth and the nares. And what happens in case someone has inhalational burns, they are at risk of airway obstruction because of the airway edema. So we came in to secure the airway for this patient and also started a low-dose steroid at that time. Breathing, he was in respiratory distress in view of the respiratory rate, the SpO2, and also the chest asymmetry with a hyperresonant left side and reduced air entry to the left. So we were worried about attention pneumo at that time. This patient was connected on high flow oxygen via non-rebreather mask, and immediate finger thoracostomy was done. Circulation, the patient was at risk of, the patient was having catastrophic bleeding, but the patrol team had applied the tourniquet. So we just had to confirm tourniquet tightness, recorded the time at that time, put 2 large bore cannulas, started IV fluids and also started IV TXA 1 gram bolus, and an infusion was planned to be given on the way to the level 2 hospital. Also at that time, we planned to start our transfusion. So under sample history, this is a patient who was previously normal. So you find that most of the history is actually normal, unlike the signs and symptoms at that time, which is a bilateral traumatic lower limb amputation, shortness of breath, bilateral hearing loss, and severe pain with multiple shrapnel injuries. The allergies, none known. Medication was on none. Medical history was previously healthy, no known chronic illnesses. Last oral intake 4 hours ago, he had had his breakfast ration, and events leading up to this presentation is that he stepped on an anti-personnel improvised explosive device while sweeping a route for a foot patrol. Secondary survey, we divided it in two. We looked at the relevant positives and the relevant negatives. And relevant positives, head and neck, soot on the lips. It's very important to actually have that noted. Soot on the lips and the tongue, bleeding from both ears. And at that time, otoscopy revealed a TM rupture. There was superficial flash burns to the cheeks and the forehead. Still under relevant positives, the chest, decreased chest expansion on the left and reduced breath sounds on the left. Abdomen, multiple small shrapnel wounds on the anterior abdominal wall. Extremities, traumatic amputation of both lower limbs, tourniquets applied, multiple shrapnel wounds on both sides, both thighs, forearms, and hands. Superficial flash burns to both hands. The skin, the superficial flash burns on the anterior. The relevant negatives, the head, no scalp lacerations, depressions, or fractures. No epistaxis or septohematoma. The neck, no penetrating wounds, and no JVD since the pneumo had already been attended to. The pelvis was stable on gentle compression and no obvious deformity, no pain, no blood at the urethral meatus. Extremities, we looked at the upper limbs. Both upper limbs were active, and it helped us also with ruling out FNDs. The back, no step-offs, no tenderness or deformity along the entire spine.
Okay, so a little more information came through. So we're now running pause 3 from the conversation we've had so far. What are the possible differentials, and what would you be looking for on examination to support this? I mean, what are the possible differentials, and what's the rationale for your diagnosis? Again, we shall end the poll at 70%. Please, let's all attempt. This is a learning session, so whatever answer you choose is okay. We shall look through and discuss. What are the possible differentials, and what would you be looking for on examination to support this? Or what would be the rationale for this diagnosis that you're choosing? For those that just joined in, you're welcome. We are looking at life-saving strategies for blast and ballistic injuries. And we are midway our case presentation. And at this point, we just want to get your opinions of what are the possible differentials for the sessions you've listened in so far. What Dr. Paul has presented, what the patient came in with, what has been done, what do you think was going on in this patient, and what would be the rationale? So far, we do have 41% attempt. We'll end this at 70%. Don't forget, if you have any question, please post them in the chat. We have Dr. Major Ubapus in the chat. He's willing and ready to answer for anything that is, even if it's concerning the patient, please post the questions in the chat. We do have 49% coverage so far now. I want to end this at 70%. Please keep the answers coming in. Okay, the attempts have slowed down. At 51%, I do not see any more answers coming in. We'll end the poll, and then we shall discuss this later. Okay, poll ended. Dr. Paul, please go ahead.
So in this patient, the differentials that we came up with, the blast lung injury that presented with attention pneumothorax in view of the reduced air entry to the left, and also the chest being hyperresonant and a tracheal deviation to the right. TM rupture, that's the tympanic membrane rupture, in view of the bleeding bilaterally from both ears and loss of hearing at that time. Mild traumatic brain injury in view of the loss of consciousness for at least 1 to 2 minutes. And notably also the patient had penetrating shrapnels on the abdomen, and the lower limbs, and he was also in hemorrhagic shock that was caused by the bilateral lower limb amputation. We suspected blunt abdominal injuries secondary to the fall 6 meters away from the site of the blast. And notably also the patient had flash burns and inhalation of burns. Those are our differentials.
Okay, thank you. Now, our very last poll for this case, listening to what has transpired, what are your priority investigations for this patient? What would you want to do for this patient in terms of investigations? Thank you to all that have already attempted. We do have 229 participants. Want to end this again at 70%. Please keep the answers coming in. What are the priority investigations for this patient, given the history that you've listened to, the clinical exam that was done? What investigations would you have wanted to do for this patient if you were the one managing them? So in the interest of time, I'm going to close this at 50%, which we do have now. I'm going to close the poll at 50%. Thank you to all who have attempted.
So we quickly dive into the priority investigations for this patient. Notably, you see that some of the investigations, there are no results because they were not done in the level 1 field hospital. EFAS was done and there was absent lung sliding, otoscopy, which revealed a tympanic membrane rupture, blood grouping and cross-matching, and the patient was blood group O+, and a massive transfusion protocol was activated. Point of care labs, random blood sugar was 6.8, HB estimation using ISTAT was 8.2 grams per deciliter. But in an ideal situation, this is a patient who would have benefited from a CT scan, the trauma series, and also having an abdominal ultrasound, as we shall see later, that also blast injuries may not, other than having an injury secondary to a fall away, also blast injuries do affect the abdomen greatly. And an ECG would have been an important one, ABGs, CBC, LFTs, RFTs, and extended electrolytes, especially the RFTs, because this is a patient who has had multiple injuries and is at least at risk of hemoglobinuria. So this is a patient is at risk of myoglobinuria. So this is a patient you'd want to do the RFTs because they are at risk of AKI. Our diagnosis, we came up with a diagnosis of hemorrhagic shock, secondary to the traumatic lower limb amputation, tension pneumothorax, bilateral lower limb amputation, and tympanic membrane rupture. At that time, those were our priority diagnoses. Supportive care at that time, oxygen therapy, 15 liters by a non-rebreather mask to achieve an SpO2 above 94%, needle decompression, second intercostal space, mid-clavicular, IV fluids, blood transfusion, and then we had to maintain this patient in a state of permissive hypotension. TXA, 1 gram was given, and an infusion was started for the next 8 hours. Analgesia, IV paracetamol, IV fentanyl, and femoral nerve block. Patient was maintained warm, the stump was dressed, tetanus shot was given, and antibiotics were also given. Then the definitive care for this patient, the specific care for the different diagnosis, the tension pneumothorax, oxygen 15 liters by a non-rebreather mask. A chest tube was inserted upon arrival to the level 2 field hospital. And also we had to be careful with how we were giving oxygen to this patient. For the mild TBI, the neurocritical care bundle was put in play, head of bed elevation, very important, and also monitoring GCS so that we see if our patient, the GCS is dropping or actually getting better, because it's one of those markers that can easily tell you either your patient is deteriorating or is improving. For the bilateral traumatic lower limb amputation, the tourniquets were kept in place. Stumps were already dressed and occlusive wrap, and the stumps were elevated. And bilateral femoral nerve blocks were given for pain management. Then for the tympanic membrane rupture, the patient was, we consulted the ENT team to review the patient. For the hemorrhagic shock, most importantly is the massive transfusion. That is very, very helpful in such a patient in a ratio of 1 to 1 to 1. And these products include FFPs, the packed red cells, and platelets, which are very important in this patient. Tranexamic acid infusion for the next 8 hours. IV fluids were continued. And also, as a team, we plan to start vasopressors early enough in case we see that we are not getting the blood pressure that we want. Very fast, the surgical team was consulted, and it came in handy to help with this patient. Our disposition plan, we notified the level 2 hospital that we have a casualty, blast amputation with a blast lung who needed immediate theater. And rapid evacuation by road or air was planned, air ambulance, to the nearest level 2 facility with surgical capability. Along the way, we planned that this is a patient who should be monitored continuously. And we kept repeating the ABC every 5 minutes to see that our patient was not deteriorating. And we handed over using the MIST format, where MIST stands for Mechanism of Injury, the injuries identified, signs and symptoms, and then the treatment that has been given on the way. Thank you.
Thank you very much, Dr. Paul. This was a very interesting case. At some point, it feels unreal, but it's actually real. This patient happened, was managed, and the patient is still alive. Thanks to the team that did a great job. So there are a number of questions in the chat. We may not get concerning the case. We may not get time to answer all of them, but what has stood out for me, there are two. So one person would love to know, what was your tourniquet time? Given this patient was, I noticed the patient had a tourniquet right to the disposition plan. So what was your tourniquet time? And then the other person would love to know, there was a concern on inhalation burns for this patient, inhalation injuries for this patient. Why didn't you intubate the patient right away in field?
Okay.
Yes, can maybe use that for the next, over the next 2 minutes?
Thank you, Tim. Those are very, very good questions. Ideally, in an ideal situation, anyone with inhalation burns, it's very important to protect that airway by intubating that patient. But you have also to bring in the factor of resources. What resources do you have? If you intubate this patient, then what? Do you have a mechanical vent that you're going to put them on? Are you ready to start ventilation at that very time? So those are questions that you're asking yourself. So the reason that's why we give DEXA in this situation, we are trying to buy ourselves time to see that this patient gets to the level 2 hospital, and then we carry on with intubating this patient. Tourniquet time is standard time of 120 minutes, plus or minus. But standard time is 120 minutes. Yes. But you also weigh your options. Releasing a tourniquet and losing the person. Those are scenarios that come in handy as a physician that you, or as an emergency care provider, that you have to ask yourself. If I release the tourniquet after 2 hours to spare the limb and I lose the person, then what's the aim? You lose the aim. So sometimes it tends to vary, but tourniquet time, standard time is 120 minutes. Thank you.
Okay, thank you very much, Dr. Paul, for the questions that have not been singled out. Trust me, we shall answer them. And Dr. Obapus is in the chat. He's answering some of them. Okay, so right now we move to another amazing session of this presentation today. And we move to the on-scene care, transportation, triage of patients that are having ballistic injuries. So over to Andrew Okiro. Like earlier introduced, he's an emergency medicine technician, and he will be taking us through what would ideally be done for such patients. You're welcome, Andrew.
Thank you so much, moderator, and thank you so much, Dr. Paul, for managing patient. I'm going to talk through the pre-hospital care, what we would do for this patient. And now the key things about pre-hospital care largely rotates around the kind of team that will respond to this patient and what kind of patient you go and pick, with which equipment do you need at your disposal to adequately respond to such a case. This inclusive of what means do you need to deploy to be able to safely evacuate this patient. And of course, where then would such a patient go? So the final destination or the disposition is also very important. Because such a patient wouldn't want them to go to a health center to would prefer a definitive facility where they could get better treatment. So then, I hope that is clear for us. We can see it clearly. The words are small, but this is the gist of everything what we do in the EMS. And this is an ITLS algorithm. It's an open source document. We could go and have this. It's also a special tailored pre-hospital care training that helps us to adequately respond to trauma patients out of hospital care. Now, it's just a simple flowchart that I hope we'll go through it together in the shortest time. Now, the first thing, of course, is the scene size up. And I'm glad that someone asked in the chat, one of the expectations is how to ensure the safety of the scene, given the kind of situation you are having, an IED. And these are common incidents we've had here in Uganda as well. I hope we all remember the 2010 bomb blasting, sad really, and may those who left rest in peace. And we also remember the most recent, the Koki Tower, and this can continuously happen, or it can happen at any one point in time. So when this happens, of course, it's important safety comes first. And this is immediately receive a call to go and respond to this patient. So first thing is the safety of the scene. Is the scene safe for us to approach? And now, when you're dealing with this kind of incidences where we have explosive, this is not just a go area that you just bump into when something is secure for you. And in most cases, the EMS, we are not the experts of dealing with the safety precautions of explosives. So in this case, then you'd want to call for help. Or if the experts are already on scene, then you'll have to wait for that clearance for you to access the scene. And usually, the experts are the ones who will demarcate or sort of cordon or zone of the scene for you, such that when you arrive, they'll guide you on where you operate from and how you can access the scene. And most times, in this case, the cordoning can happen it can be put into 3 categories. The first is the hotspot where the explosive actually is, or the point that is boiling. And this can be the hot zone, which is usually red. And most times, how big that zone can be, of course, most times can be determined by the security experts, which I'm sure can be dictated by the magnitude or how heavy the explosive could be. Then that will then make them know how big the hot zone can be. And that hot zone most times is not accessible to anyone. It's only to the experts who can deal with the explosive to clear them out. Then we have the warm area, which again will be determined by the experts most times, and then the green zone. So the green zone, this is when you arrive at the scene, so they'll put you in that place. Then you wait for clearance from the incident commander for you to approach such a scene. Then the other thing again that is important is we're glad that this was one patient, and we all know that most times with explosives usually can tend to take on a bigger radius, and this can affect property, including maybe people who are close to the scene, who perhaps were not the intended or the target. So maybe this was a guy who was sweeping and people were passing by. So it tampers with the explosive, and then the innocent ones who are just moving around get caught up. So it's important when responding to such a case to know how many patients you have in the scene size. So in this case, you have one patient. This information you can get from the bystander or someone who has called you to respond to such a case. Then again, of course, if there are many, then the triage comes in. And of course, we know the triage is standard. We use the same red, green, and yellow. And then this, you had one case. So we just basically going to pick this person. But most importantly, again, is we need to know, when we want to know how many patients, but we also want to know what is the age perhaps of the patient. Is this a child? Is it an adult? So that when we're having the materials that we shall need for helping this patient, you know the appropriate material to use, or even the appropriate facilities to dispatch. And then lastly, calling for help. The kind of help we would want here can be in 3 forms. One, this could be peer expert help. Perhaps maybe you need an extra professional with a higher skill set. If the patient is very critical, that can happen. The dispatch can perhaps maybe get a a critical care specialist above an EMT to support in the response. Or just at the scene, the other help you might need is of the bystanders around. Support you maybe in lifting, in giving you some information, or in protecting the scene for you, things like that. And then, of course, the last one is, and these are also very important people always consider when you're giving care. These are the relatives or the attendants, people known to the patient, because they can also give you more information, but also they can be willing to support compared to the bystanders. So they're also another special people we need to call on to support us. And then, of course, last, the mechanism of injury is important as you're responding to know where you are going. So this was an explosive incident. So the kind of mechanism here is we are responding to an explosion, which can bring a lot of, there can be a lot of mechanisms here. There can be a fall, there can be penetrating injuries from the sharp nails, etc., and so on. There could also be blunt injuries. Someone can just fall from a blast wave. So this is very important for us to know that information, so that as we're responding, we know what kind of patient we are expecting to deal with. So when that all is sorted, you arrive at the patient, your initial assessment is very important. And in this case, we are not focusing on using a lot of equipment. We are focusing on those very life-threatening situations that we can manage immediately at the scene. Priority here is to rush the patient to the hospital. So, and here are basically few things. Number one, what is the major chief complaint, or what is the key thing that you're able to see on the scene? For example, just arrive at the scene, you see a patient lying on a pool of blood. That is message. Either this patient has lost maybe a lot of blood, or you just find the patient just lying unresponsive. That also is message to you. Or you find the patient is complaining and is crying, my leg is hurting, and so on. They are trying to inform you where the challenge is. So that is very important. And for this case, we also, this patient had both legs off, they're amputated by the blast. So of course, we would expect this patient to be in a pool of blood, the legs are off. So priority here, we would want to do our quick CABC. The small c is to arrest any catastrophic or execution hemorrhage that you're seeing actively bleeding. Not those that have stopped bleeding, that is actively bleeding. Or maybe you see an arterial bleed, or you see just a gush of blood that is actively bleeding. So you need to quickly direct pressure or tourniquet. Stop that. Before you even go for anything else, we need to stop that blood from getting out, those that you can see. Then you go for your quick ABC, airway, ensure that it's patent. Of course, and most times these people get generalized, they can get multiple traumas from you cannot know where the trauma is at that point. So you have to protect their C-spine as you're managing the airway and make sure that it's open. The other important thing about when you're managing the airway, it's important to assess what are the possible things that you can find out in the airway that could be life-threatening in these incidences. Of course, the hazard you would expect would be fires, sharp nails moving around. So you have to inspect the airway, ensure that there's no bleeding, or there's no object or anything that is in the mouth. Checking if there's any burns and so on. And then ensure that you correct that. The breathing, we just want to ensure that this patient is breathing. We check, is the patient breathing, yes or no? And in this case, our patient we saw was already in distress. And most times we need to find out this distress, what is the major problem here that I need to address. The SpO2 of our patient was 86, so definitely the patient needs some oxygen. And our patient also was in distress. So most times we know with these blast injuries, blast waves, they can also cause sometimes a lot of barrel trauma. And most times this can result into things like a pneumothorax, which you just find the patient difficult to breathe in normal chest, it actually got a barotrauma. So you need to ensure that you properly assess to rule out the pneumothorax. And if you found any, then you have to decompress that, especially when it is at tension. And then, of course, if there's any visible injuries on the chest, maybe there's any sacral chest and so on, you need to cover those because those also can result into pneumothorax. And then the other important thing in this case with trauma is most times you don't want our patient to be in shock. So you quickly assess for quick signs of shock, capillary feel, extremity, how they feel, what is the pulse, how does it feel, is it steady, is it so fast and so on. And for our patient, actually, the patient was in shock because the capillary fill time was written at 3 seconds, matched by a rapid pulse, and with the bleeders that we're seeing around, the 2 fractures, so the 2 amputations. So this patient definitely could be having an hemorrhagic shock. So in this case, priority is we'll have stopped that bleeding in the first arrival, but then you need to start immediately 2 large bore fluid resuscitation. And then we all know TXA is good to give it early. So if you have it at your disposal, better, this is the right time also to give it because we know our normal challenges here. You might want to move and getting out of the scene where there's an explosion. Most times you will expect to find jam, the cordoning off, redirecting cars, people very many crowding all over, others. And we all know, again, how people respond. When they hear there's a blast in one direction, everyone, those close to the scene will first want to run away. When they reach a safe place, they want to come back to get more information or capture TikTok videos and so on. Then those who heard where the blast was want to go there and find out what is there. So now with that chaos, you might take longer to get out of that scene. So which is why some of the things, you need to start them as early as possible. And then when that is done, so you have now from our patient we saw was having difficulty in breathing, was in shock, and so on. With the mechanism of injury that we already had, we now need to quickly decide, is this patient having a localized trauma or it's generalized? And of course, for this patient, it was a generalized mechanism of injury, it wasn't localized. In any case, whether it's localized or generalized mechanism of injury, at the end of the day, what we are interested in is, do we need to stay at the scene and have enough time to treat this patient at the scene? Or we need to quickly do what we can do at the scene, for example, stopping the bleeding, start the fluids, immobilize the C-spine, load the patient, and then go. And most times, that decision will be determined by the category or the kind of patient you've had. So of course, if it's a red patient, this is a very critical patient, then that means you cannot stay at the scene and play. So this arrives us at that level of whether this is stay and play or load and go situation. A load and go situation means the patient is very critical. You don't have much time at the scene to treat the patient. This patient benefits from the hospital where you find Dr. Paul and the team, because there they have the x-rays, they have the POCAS, they have the nurses around, they have whatever they need for this patient. In the field, you have only you, the driver, few bystanders, people around you, and your ambulance, nothing else. So you have to get off and go. So if this is a load and go situation, of course, this patient definitely qualifies for that. Then the other things, the secondary survey, you do them as you're moving to the hospital. Taking the blood pressures, the RBS, all the things, you do them as you go to the hospital. Taking a sample history, most of the things, immobilizing simple small fractures, dressing simple wounds, these you will do them when the ambulance already is en route to the hospital. Now, lastly, for this kind of response, it's also important not to forget to document in the PCF form whatever whatever you've done for this patient, and then hand it over to the patient. And of course, the handover, of course, has to be very systematic and a professional way. Largely in EMS, we use our DMIS, but there are other different formats of handing over, which usually package the same information. And my last word now on this again is, after such a response, it's always very important, especially for these very critical cases, very rare situations that happen, if there's any near miss and so on, or such a patient, important to always do a debrief for quality improvements and making sure that when you have such a case again, if there were gaps that you had in this case, if another thing like this happens again, you will do it better. Thank you so much for listening.
Thank you very much, Andrew. That's well summarized and well put. People kept complaining that the slides are not moving. He explained everything on the slide. It was in one slide, everything. So thank you so much. That was well put. I think someone who had a concern on what are the scene safety measures that have to be put in place for such cases, I think he has put this up quite so well. And to the person who was concerned that the patient wasn't intubated in field, I think he tried to put it up there. Is it a load and go case or is a stay and play? So I think he brought up all those principles quite so well. Now we move to another amazing part of this session, nursing care. So with me, I have I hope I pronounce it well, Lieutenant Jackson Gutagwa. He's taking us through the nursing care for ballistic injuries, and you're welcome.
Thank you, Doctor, for the time. And I want to say thank you, team, for the earlier presentations. The case at this point, I think the nursing part is going to be very easy. Most of the preps have been done. I want to say that nursing first starts from, it is picked from where we all come from when we are babies. We all say that breastfeeding mothers are nursing mothers. So nursing starts from caring for the vulnerable. So that's where the people that defined the wave or the profession of nursing picked the inspiration from. So I want to first make a quick statement before we go to the slides, that in ballistic emergency care, the nursing concerns are about pain control, prevention of further injuries or complications until the time of discharge or transfer to a facility where patients can get better care. So all we're doing is we are doing observations, we are doing interventions, we are documenting, and we are observing again. So the concept is do pain control, avoid further injuries or complications until either discharge or transfer to a better facility. So I now would want to go through the presentation as we execute this. Thank you. Yes, the next slide, thank you. I picked a few nursing theories that define nursing and the profession of nursing. We will see some are grand theories and other we call them middle-range theories. The grand theories are the native long-time theories that tried to define nursing in detail. And for this, I fell in love with a theory by Virginia Henderson, who wrote the nursing theory, what is called the needs theory. That when patients come to the hospital in such a casualty, you assess their dependency to you for nursing. And all care provided moves towards making sure that these people can care for themselves as though they were okay. Because when people are sick, we are used to nursing, making beds, giving bed baths, we're providing commodes, we're feeding our patients. So ideally, when a patient is okay, they can't do all these things by themselves. So we're having a patient who has got a bilateral lower limb amputations, who can no longer walk. So he's more dependent on nursing for everything, from hygiene, from eating, and all the things. So our goal for nursing care, in view of Virginia Henderson's theory, is that at the end of the care, this person should care for themselves without the hand of the nurse. And then the middle range theories look at few concepts in nursing. So one person wrote the theory of a deliberative nursing process that must include the patient in identifying the patient needs, not as superimposing what we think this is what the patient actually needs. And then the other theory is the balance between analgesia and side effects. And of course, the last one is chronic sorrow. Allow me to talk, let's go, as I talk about chronic sorrow. The theory that looks at chronic sorrow, the next slide, please. It is built on a tenet that due to ongoing loss or a single event that was caused by, can cause a lifetime grief. So it's like the precursor for this theory is the writer was looking at mothers who have had children with bony disabilities. That every time they look at their children, how their children present triggers another wave of sorrow, which is most likely going to happen in our patient. That even if they go to prostheses, every time they wear them off and look at the stamps, they are going to be, their psyche is going to be traumatized. And then the balance between analgesia and side effects, that patient satisfaction with the relief of pain should be seen, and with the absolute relief or absence of side effects. We've all given patients different drugs, maybe like tramadol. So, and the pain goes, but then the patient is vomiting. You get it? So is vomiting a better feel than the pain they had? Or you give a pain relief and then somebody gets an abdominal pain. So that the theory that looks at the relief of pain and absence of side effects is one that I thought will guide us in this presentation well. Let's go on, sir. So the nursing concerns in this, one is CBAN. As the presenter has said, we are having an increasing level of blast and gun violence. So we're having an increase in chemical, biological, and radiological, or nuclear and high-yield explosive threats. So when you receive such a patient, part of our greatest concern as nursing is safety. So you don't want to be exposed to what you do not know. The case presenter told us that this patient came with a visible soot on the mouth and nasoneas. So maybe this patient had a chemical exposure to even the other handlers. So this is a patient that had to first go through what we call a decon or a decontamination station. Wash them out clean with the proper PPE, and then have a patient who is not a disaster to you and other people in the facility, either from nuclear or radiological or biological exposure. Then the other is shock. I wrote it as risk for shock because that's how our NANDA, the Nurses Guide for Nursing Diagnosis, defines shock. We rarely do conclusive diagnosis, but a risk for shock was top in my considerations in this case. Then the compromised tissue perfusion. We're looking at temperatures below 36.0. Pain is high in there, ineffective thermoregulation, the patient is feeling cold. Altered skin integrity, we're having shrapnel, abdominal wounds, and flash burns, loss of hearing. And this was in both ears. The TM was ruptured. I don't know whether it was ruptured and the sense was still there or the patient actually lost hearing. So if the patient lost hearing, you just realize that even how we communicate to the patient becomes harder. So we can no longer do pain assessment by verbal assertions, okay? And then chronic sorrow is coming in there because the patient has lost both their limbs. This is 35 years, probably was a father married to a beautiful woman who loved her walking up straight and sat in a soldier, and then is returning home in a wheelchair. And then a disturbed body image or altered body image. So we should, let's move on. We should stop thinking of nursing interventions just by the physiological needs, but also with the physical needs. So one of my diagnoses was the risk for shock related to severe hemorrhage. A nursing diagnosis should have evidence, but a risky diagnosis cannot have evidence. And because NANDA treats shock as a risk diagnosis, but at least this one, the evidence was there. We're having diaphoresis, we're having BPs of 80s out of 52, the pulse rate is high there, the patient's having cold extremities, the respiratory rate is in 32, and we're having an SpO2 over 86. So this is just typical shock. So we are looking at our goal is to stop progressive bleeding as soon as possible, and then return blood pressure to near normal in at least 3 hours. You wouldn't expect to pull it in a few minutes to near normal. So what is the rationale? The interventions are written in there. We're doing check tourniquet. We are not saying that EMT didn't do a good job, but of course there's a gush of blood, and then you're loading, and he used the term that load and go. So in that, let's load and go. It is easy to put a tourniquet, but it is not effective. So when you come to hospital, you want to recheck and see, is it really tight enough? Am I having active hemorrhage, or am I having capillary spillage? And then if it is implied, you may have to put a counter tourniquet above the initial tourniquet that was put by EMT. And then you apply pressure bandages to even stop the simple bleedings that are still there. The other is you want to secure a large bore cannulas. Because doctors are going to come in with a lot of resuscitation. It's either fluid or blood. We're giving drugs, and we don't want to go for small gauge cannulas. And then you are administering the prescribed fluids in the duration required. It could be by just bolus, or you're using fluid pumps, or certainly fluid pumps. You cannot go for syringe pumps in this case. The rationale, we want to ensure there is effectiveness in stopping hemorrhage. And we want to optimize IV access and increase saturatory volume. So the evaluation you can always have different outcomes in the evaluation, because it is not true that for all right interventions, you will have the rightful outcome. But as the patient responds, certainly you can have an evaluation. Let's have the next slide, sir. And the other is the other diagnosis we're looking at: ineffective peripheral tissue perfusion related to severe bleeding and compromised chest. And a compromised chest evidenced by the low saturation. So the SpO2 is there, the respiratory rate, and then the CR that was above 3. Our goal here and interventions, we want to maintain oxygenation and ventilation, and also maintain optimum body temperatures. So the interventions, I thought it is good that we assist the patient into a high Fowler's position. This is more sitting, and of course is having lower limb amputation. It becomes a little tricky when you also want to elevate the stumps, and then the patient is sitting high. So priority is set to the airway. So we want this patient seated high, and of course we are giving oxygen in the manner and volume that is prescribed by the colleagues. We have to cover this patient with warm beddings, or even put a patient warmer. So the rationale here, we're looking at reducing weight on the chest cavity. We said there was asymmetry, so probably there was a frail chest, and so you don't want to keep that segment that is swinging on the patient while lying flat. So when they're more sitting, you think it is either more immobilized and they can try to breathe out well. And of course, there is a tube that has been inserted underwater seal to drain out the pneumo. And then we want to provide optimum environment for saturation. If a patient is cold, it is unlikely that you will actually have optimal saturation. Allow me to go to the very last nursing diagnosis. These, I think the slides will be shared. Maybe, yes, that last one. We're looking at bilateral traumatic limb amputation in assessment. We are having hearing loss in both ears, and disturbed body image related to absence of body parts, as evidenced by the bilateral traumatic limb amputation and loss of the sense of hearing. So these two are key great triggers for chronic sorrow. But however much we would want to allow the patient to go through normal grief. You cannot diagnose them for having chronic sorrow before you've seen whether they have gone through normal grief normally. So you want to reduce how many people are visiting them every now and then. You give them time for self-meditation. you're giving them a quiet and clean environment and cool enough and well spaced to make sure that whatever is really running in their brain about their loss, they can think about it, and when you come in, they can give you a functional discussion. And when the period of normal grief is past, want to start routine counseling and referral to a rehabilitation facility. We think that they can get processes, they can get trained on using them, fitting them, and then physio. So I chose this that we don't think that nursing in a hospital setting will cover disability. So the option for referral for a rehabilitation center was a priority for me. And then let's have the finishing sessions. Yes, those are my references, and I want to say thank you, Tim, and thank you for calling us in this.
Thank you, Lieutenant. That was an amazing view of nursing care.
Sure.
Yes, I hope we hear more of those theories. So now we're going to our key expert of the session, Dr. Priska, but shortly before she comes in, would love to hear from Major Dr. Obapus Robert. As a field doctor who has handled a lot of these patients, who has handled a lot of patients in the category of mass casualty, what's your experience? How do you manage in? What would be your take home? What would you tell the team? What would you tell another doctor who is possibly handling these patients for the first time? What would they expect? What would they do? What's the special message you would give to us? Dr. Papus, over to you in the next 5 minutes.
Thank you very much, the chair lady, Dr. Anna, and all the panelists. Yes, of course, not forgetting my colleague there, Captain Dr. Sekate. Thanks, that was a wonderful presentation. It was so informative. I have some concerns. I've tried to answer it in the chat. I hope the colleagues there are following it. Yeah, basically, managing this blast injury patient in form of, mostly because they don't occur in isolation. An injury, a blast injury occurring, you are very sure you're going to have mass casualties. Now, often, it's good that this scenario had happened to a colleague who was an IED expert, was trying to detonate it. But if we get situations where you are taken by surprise, occasionally we get a VBID, that's a vehicle-bound improvised explosive device, where a whole vehicle rams into public. And this is a mass, it happened in I remember 2017, which has broken the international world record, where we lost over 600 people in a single explosion here in Mogadishu, and the whole country was overwhelmed. Actually, it was helped by international agencies which activated their systems, and the planes were flying in Mogadishu like taxis. So just telling you, I'm just bringing that background to show you the extent of damage these bombs can cause. Now, in management of these patients, basically needs a multidisciplinary teams, involving multidisciplinary teams. Now, in the initial assessment, you need well-trained team staffs. You don't need people who are highly educated. You just need people who are good at doing the basics of saving life, care under fire. Because this is in our scenario, in our situation, the initial effect is care under fire. Before you can relocate your casualty to tactical field area, which is relatively safer, as you escalate the level of management. Initial assessment involves stopping hemorrhage. If your teams in the ground, in the field, are not capable of handling or stopping hemorrhage, the rest of the advanced teams will do nothing, literally do nothing, because the results will always be poor. Before having organized for evacuation of these colleagues, the initial responders must be very, very accurate, very, very aware of the consequences of leaving these patients unattended to. Now, you need to handle airway, breathing, and saturation concurrently, and make sure you take care of the hypothermia. Those are the key life-threatening scenarios. Now, when they escalate them, when we evacuate them to level 2 facility, that's according to UN, level 2 facility in our setup in Uganda is equivalent to a regional referral hospital. When we escalate this patient there, we have organized teams. We have people arranged the teams. The moment this incident occurs, we are activated. You activate teams, call for help. That call for help is the first, because all the things are occurring concurrently. The teams are already in drills, waiting to intervene, to pick casualties, and everybody knows their role. Now, when these casualties come, we prepare those one, first priority management assessment. First, labs are taken, everything is handled concurrently. Blood grouping, and those ones who need damage control surgery, intervention is done there, and then theater, every team, ICU, every team is prepared and ready to take on the patient. So that's basically how we take on this patient. But by and large, it's multidisciplinary teams. And among all these teams, we have all different specialties. We have physicians, we have surgeons, we have ENT, we have all categories of people involved in these teams. That makes our work easier. We have point of care imaging, ultrasound, even X-ray. But of course, as you understand, first is a gold standard. I mean, it's not a gold standard. CT scan is a gold standard, but then CT scan delays what and so on. So because of the reliability and availability and its sensitivity and specificity, first offers you almost 90 to 100% benefits of your intervention. So you won't go wrong when you tailor your management towards that. But again, the key aspects of medical pharmacologic agents are stated by colleague Dr. Sekate. That's basically all these things are in our fingertips. You have to make sure these teams continue medical education every time they are doing rehearsals. These teams all the time, because here we are in a trauma setup. That anytime things go wrong, anytime, can be night you are sleeping and a bomb lands on you. Fire can be direct or can be indirect. So mostly our big worries are these indirect fires, because they can send a bomb from nowhere. Now, when it comes, the team has to be very, very agile, very ready. People sometimes there is a team which sleeps on standby, just in case. Because even for us here, we also have as a facility, apart from taking care of the troops, we also handle the community. So all this, we integrate them to ensure nobody's left behind. We also have the airport. All planes sometimes crash here. So when they crash, we also have to intervene. So this has widened our scope in experience and ability to handle such cases. But basically, again, these teams need to come together and keep training, keep understanding what went wrong. After every intervention, we do AAR, after action review. We review what went wrong, what did we do good, what did we do well, where was the challenge, how do we improve. So all this must be tailored together in order to maximize the best outcome. Basically, that's what I wanted to put across. I don't know if I will get time to answer some of the queries, maybe one or two. Lady Chair, am I allowed, or can
we do that in the next, after Dr. Priska has presented one? Is there any particular one you wanted to focus on?
Perfect, I can hold on, and maybe I'll give one or two when you give me opportunity. Thank you.
Okay, sure, I will. Thank you so much, Dr. Obapus. That was just having you on this chat it felt like we're doing field medicine. Thank you so much for honoring our invite. Over to you, Dr. Priska. You're welcome.
Thank you, Anna, and thank you to my panelists, presenters. for the interesting discussions so far. So we shall just focus a little on emergency department care for a patient who comes in with a ballistic, and that's usually a gunshot wound or blast injury. These two are not exactly the same, but they have a lot of similarities in their assessment, in their management, and in terms of the disposition. And we've had a lot of intel from the two presenters so far in terms of the nursing care, but also from the case itself and from Andrew, who gave us the pre-hospital introduction. So they do not differ so much, but the idea here is that we have to save this patient has life-threatening issues, and the goal is for the emergency provider is to really stop those life threats to them so that they are able to dispose them to the rightful place, which is often an OR, an operating theater, or fly them to a place, a level. Someone mentioned here, it should be a level, a trauma center, not a health center 2 or health center 3. So we're going to just dive deep into that for a bit. And I started this by telling us, because the poster had ballistics and we haven't had that word yet. And what are ballistic injuries? Ballistics generally is the study of motion of projectiles, and it has what we call the, internal ballistics, which is really not for us, and it's for people who are experts at guns and the like. Then it has what we call external ballistics, where we study the motion of how the bullet moves out of its gun down onto the body, where we see now the terminal ballistics. So as emergency providers, we take care of the terminal ballistics, what the bullet or gunshot does to the body, what effects it will cause, which might not differ from what the case we just had, the tension pneumo, and the like. So I added that just because I'm very interested in guns, not that I'm violent, but it's very adrenaline. It gives me an adrenaline thrill. And so ballistics depends on the type of machine. The terminal ballistics may depend on the type of machine that has been used to shoot a patient. We have there 3 types. You will correct me, colleagues, but I think the top one is a shotgun, and then a rifle, and then a handgun. And all those will have different shapes of bullets, different pressures in their bullet compartments. And that might determine the velocity of the ballistic itself and how it injures the body. And the lower image is just to tell us that these bullets, whatever the size, they'll apply pressure on the body, go through and create a permanent cavity, which is a typical hole wherever they are passing. And out there, they are also compressing the tissue around it because it's pressure, it's kinetic energy. So as they move through the tissue, you have a temporary cavity surrounding that bullet that's moving through the body. And further apart, that energy is also applied to the distant organs. For example, if it's coming through the skin, it might apply some pressure downwards to the heart or to the lung, to the hollow organs. And so at the end of it all, you have 3 types of injuries. The actual tissue that has been injured, where you might find the cavity where the bullet passed, the tissue that got stretched out, so muscles, if it's the lung tissue itself, and the like, and then maybe bone that might receive some waves from the bullet. And all those may be seen later as injuries that are causing life threats to the patient. So yeah, those are just different types of bullets from those 3 kinds of guns. And the approach doesn't really differ grossly, as we've already seen. I think Dr. Sekate, Captain Sekate, mentions some very interesting things. And we would start out with a primary survey, which is really to identify, treat, and reassess our patient of all their life-threatening injuries from the ABCDE, from the external hemorrhage down to the ABCDE. And then that's usually done immediately that these patients arrive at the emergency department. Literally within the next 5 minutes that they arrive, you're already taking over their care and calling your team for help and allocating roles as quickly as possible, as Andrew highlighted. And you have your nursing team ready to help you with all those extra things, the large bore cannulae, and a team that's probably experienced and has had ITLS or ATLS and a lot of drills to do with a response to a trauma patient. And in this, we aim to resuscitate. Then in the secondary survey, we go back and do a head-to-toe exam, looking for what we missed and trying to get to a different, definitive diagnosis. Most times in ballistic and explosive injuries, we miss the folds. So the patient, you might keep wondering, I'm pouring in all these fluids in my primary survey, I'm giving blood, but nothing is happening. And yet they're bleeding in the brain, yet they're bleeding in the armpit or down in the peritoneum. And those are things that you can only see in the secondary survey. So that's the goal of a secondary survey, to go and look for those things that you might have missed. While in the tertiary survey, which is done much later when you have labs and extra investigations, you're able to now put it all together and see those extra things that might kill them later. So as we do all this, as I've mentioned in the secondary survey, we're doing a head-to-toe assessment. So we need to look for what our trajectory was. As an emergency provider, it's not a must for you to know what the exit and entry wound is. It's good to know, it's desirable. However, if you have an idea, you should have an idea of what one looks like. And in our image there, we have an entry wound and an exit wound. And the goal of knowing this is so that we do not miss a retained bullet. So we look besides the history, as we shall see ahead, we look for any extra wounds. You should have at least an even number of wounds. If there were 2 bullets, you should have 2 exits. But if you don't, then it gives you an idea of what is left inside there and why you need to go back, and definitely tells you what the hidden damage might be. However, on the previous slide, it's also important that some ammunition, some recent changes, you might not really be able to tell at all. They might look the same. They might all look shattered from the entry to the outward. So that's why it's important to just treat those life-threatening things and then identify how many wounds per se that you have. We talked about the secondary survey. The sample has already been highlighted to some extent in our case presentation, where you're looking at the signs and symptoms. And in our patient, we had difficulty in breathing. He was crying excessively from the pain of his bilateral wounds, bilateral amputations. And then he had a mild head injury, meaning his level of consciousness was also probably a bit low, or he was confused. But now we need to ask a few other questions that might help us determine what kind of wounds should we expect. So the weapons that I just mentioned, I'm not an expert, but there's the low velocity and the high velocity. And it's really self-explanatory. High velocity, like a shotgun, will give you, or a rifle, will give you a very bad injury. So that means they might get polytrauma, it might ricochet more. And then low velocity might be a bit more manageable for us without probably, it might buy us more time. We need all these patients to go to the right place, but that might buy you more time because it might not be as debilitating as the high velocity ones. And then you need to think about the distance between the person who was shooting and the organ that was being shot. So, and then the angle of the shot, because that determines how it probably moves through the body. And the likely organs that are going to be involved. Is it the bone? Is it the bones that are involved, etc.? And then the number of shots that you had. I've already talked about the even number, and then circumstances of the injury. Maybe this person was trying to kill themselves because they are depressed, and you need them to be followed up after. That might not be urgent or emergently needed while you're responding to the life-threatening things. However, for follow-up, and he has made a good job talking about the nursing care, chronic sorrow. Okay, maybe this person needs to be seen later with a psychiatry, and they counsel them, and their family needs to be beside them all the time, just watch them and take care of him. Yeah, so that's just a bit about the gunshot wounds. We shall see the management together because it doesn't differ. So for blast injuries, these have become more and more common, as someone mentioned. We've had July 11th, 2010. Now we had another incident of over 500 people dying in Mogadishu. That's not Uganda, but those were some of Ugandans being involved. And several countries recently, we saw something in Doha, and all the UAE, whatever is happening. So these things are becoming more and more common, and the more we get exposed to the information, the easier it gets to treat our patients easily. So what really occurs in a blast injury is you have an overpressure, meaning a shooter, because these things are contained in a container, like it could be small like this, but it's under pressure. And once it explodes, there's a lot of pressure in the environment that bounces everything out of its radius. And then there's a negative pressure that sucks everything in. So as you can imagine, that's push and pull. So all those decelerating injuries, like you've been pushed and then thrown back, and that's going to give you multiple system injuries. You're going to get several people injured. You're going to get destruction. You might get electricity coming down on a building collapsing. So both property and people. And that affects a lot of recovery in the public health sense, but also the recovery of the body itself because it's polytrauma. And so in these patients, there are currently 5 categories of blast injuries. As I mentioned, there is an overpressure, and that's usually that first wave is responsible for the primary injuries. And the commonest, as we might have already seen in our patient, is blast lung, and then blast ear, and then blast gut or colon as the commonest organs that are involved. And then we have secondary injuries where you have the particles or fragments that are in that container that has the explosive moving out and injuring people. So with shrapnels, and our patient again, so our patient literally likely had everything. They had the primary injury, then the shrapnels that were all over his skin. And then we go to tertiary where you have some blunt trauma because you were thrown out and you hit an object, or an object came and landed on your body. And they can end up with, head injuries, can end up with actual blunt abdominal injuries. It could even be penetrating. And then you have the burns. Again, our patient had flash burns to their face and neck. They had flash burns to their hands, and then inhalational burns. And in there, the inhalation can be as much as inhaling toxins, because these same things will cause burns of the environment. So you have carbon monoxide poisoning, and then cyanide poisoning. And then lastly, the quaternary injuries where you have quinary, where you have just extra chemicals that are in the environment, like historical Nagasaki, that one, where they had things that are happening for a long time, and they would give birth to children that are having disabilities or no arms because of that chronic chemical toxicity. So that just summarizes exactly what I've been talking about, some of the common injuries that we see in the different classes and everything else. So what really leads to our patients getting good outcomes or bad outcomes might depend on our system, and response system is in red. And we were just discussing this at lunch, that in Mogadishu, the resources might be there. People have seen these a lot of times. So drills are actually not drills, it's their reality. So they know what to do spot on. And so triage, time to care, and resources affect a lot of our patients. Now, come down to our emergency department in Mbarara, those resources may not be the same as in a military setup where this case ended up and survived. For us, our patient might not survive as well, likely because we don't have enough practice with those injuries, but also likely because, well, the resources are not there. Even if we had them, maybe if we had them, we would do a better job. And then explosive agents, what size of the explosive is it? And what's in there? What kind of gas is in there? What container is it? How much pressure does it cause? And then the patient patient themselves. For example, their age, if they're elderly and then they're into a blast or a very little child versus a young, able-bodied man of 30 or 25-year-old, maybe their survival or injuries might be less because their physiology is better. And then exposure, how long have you been exposed to these things? If it's a chemical, if it's cyanide, how long have you been exposed in their organs? And finally, the distance from the injury, where is it located to you? Are you in a building? Studies have showed that if it happened in here in an enclosed space, we would have a worse off because all the positive pressure is in here. Okay, so we shall just have bad injuries compared to the people that are outside in the lawn. Okay, and generally speaking, these injuries, they might not turn out to be that many, but they are very lethal. And that's why we worry about this. That's why we need to be trained and be exposed to this. Majority of them might get minor soft tissue injuries, and those are the ones that might come to your emergency departments earliest, sadly. And then the one who has the worst image, the 30% or 11% with amputations, because they can't walk, they're just screaming, everyone is anxious and running, they might be left on scene. So our ITLS or ATLS principles come in handy. Who is that person that should be loaded and taken immediately? Who can we say we do the most good for the majority, okay? Because in that moment, we have very many casualties, everyone is screaming, even the one that has a scratch on their hand will be screaming because of anxiety. So, and we shall have also very many dead ones in that regard. So what do you do with them? So it's very important for us to triage, of course, as we've already highlighted, but also it's important to know what are those common things. And when you see that, someone mentioned red flags. When you see that thing, what does it tell you? Okay, if you have a blast ear, that's telling you that your hollow organs, literally all of them, have faced something. So you don't send that patient home. And then we've talked about blast lung, and the commonest there is contusions. Again, because of the whole deceleration, acceleration, being bounced out and pulled back in, and they end up with contusions to their lungs, and then expansion of air and pulmonary embolisms that end up injuring their vasculature lung. And then the rest of the injuries, you can have direct myocardial contusion, and these patients can come in with actual arrhythmias, like a bradycardia or an actual SVT, because they've kind of wounded. It's like a bruise on your skin and you feel pain. Even the heart will just be agitated a bit and will give you some arrhythmias. So these are just examples of what we've just talked about. And I think at this point, it would be nice to just highlight like the case that we are seeing there that has bilateral amputations. We had that Dr. Sekate had a chance to put bilateral tourniquets on this patient. So how is that done? Can we demonstrate? Okay. So we're going to just demonstrate on such a patient. We can see a tourniquet in the background on one side, actually on both sides, the black thing on our image. So Dr. Sekate will demonstrate how we place a tourniquet on an injured limb, just briefly.
Hi, everyone. So this is what they call a tourniquet. As you can see, this is a commercial tourniquet, but it doesn't mean that if you do not have a commercial tourniquet, you should not put a tourniquet. You can actually still try and improvise using the casualties shirt. You can actually cut the shirt and use it and tie as tight as possible. So when you look at this commercial tourniquet, it has time written here. That's the tourniquet application time. So you note your tourniquet application time here. As soon as you put it, note the time so that the team that is receiving the patient, they can easily know this tourniquet was applied at this time. This that you see here, this is meant to help you make your tourniquet as tight as possible. So when you apply the tourniquet, you use this to tighten. And we are going to demonstrate on Dr. Priska. So So from the site of injury, at least we look at 5 centimeters from the site of injury or from the stump. So let's say if she has had a traumatic amputation here, so we are looking at least 5 centimeters from the site of injury. So you'll apply your tourniquet, make it as tight as possible. She'll tell you what she'll feel after applying it. So like I told you, this is just to adjust tightness. So you're making it tighter. Might hear Dr. Priska scream because it's getting tighter and tighter. As you check your distal pulses, you have to make it tight because what we are worried about is not the venous bleeds. We are worried about the arterial bleeds. So you keep checking up to when you can no longer pick up the pulses. And then, so actually right now we are not picking the pulses. So let me release it very fast, but ideally that's what you do with a commercial tourniquet, because this is already prepared to serve its purpose. But in case you do not have a commercial tourniquet, you can actually just get the casualties shut. The way of seeing like this and make it tight as possible, same distance. But in this case, we are going to use the stick to help us make it tighter. So this was easier. So you have something anchoring in, and then you're going to do the same rotations that we were doing previously. This is just a demonstration of what you can do, sorry, but it's just, you're trying to make it as tight as possible. Tie, and make sure that you can no longer feel those pulses because you're fighting an arterial bleed. You're not fighting a venous bleed. It should be as tight as possible. If it needs you calling your colleague to pull on the other side, you do that and make sure it is tight as possible. But the distance, at least we are looking at 5 centimeters from the site of injury. Put your tourniquet there, feel for the pulses, make sure you no longer have pulses. If it's a stump, you'll actually see that your blood is no longer gushing. So that will give you kind of, you'll get to know that now it seems it's tight enough. But as soon as that tactical combat casualty team comes in, they counter apply a commercial tourniquet. They should not take off the initial tourniquet. They should just apply another one on top of the other. As simple as that.
Thank you very much, Dr. Sekate. So that's how we apply a tourniquet, and it's like we saw in the ITLS algorithm, it's something we can do in the pre-hospital if you're trained, only if you're trained to use that tourniquet. If you're not, then you probably apply pressure to those bleeding wounds. Deep packing is something that you can do as you wait for the team that is actually trained to use it if you do not know how to use it. Now, the other common injury that we see is the blast lung, where they get contusions, and that X-ray just shows us the bat wing appearance, that those white things in the middle of the lung is what you might see on the X-ray. And X-ray is one of the commonest things we have in our setting. So that's why I think that it's important for you to identify if someone says, I have difficulty in breathing, and they were just involved in, even if their saturation looks good, that's something that you need to do. The other thing is definitely facial, the burns, but also actual shrapnels or any other metallic fragments that might be found. And this still shows you that you can do bone series, whether it's just X-ray, if you don't have CT where you are, it's something that you can do, but by then you should already have arranged their referral to a high level center where they can get CT scans. And more of the secondary injuries where you have shrapnels that end up, on the skin. So those are not actually inside the lungs. they are in the subcutaneous tissue. Some of them can easily end up in the bones, depending on the velocity, bones themselves. So these patients would often need to be debrided, they need debridement. So you need to do it and remove all those fragments, because sometimes they are toxic themselves. They have been coated with something and they're going to continue causing pain and inflammation on the patient, and then they end up with another set of complications. So this, as already mentioned, you can have auditory system involved, cardiovascular, GI, and those, the ones in dark gray, auditory system and GI, are some of the commonest things that we see. Our patient had ruptured tympanic membranes bilateral. That's going to be something that requires an ENT to either repair, or they may need eventual hearing aids if they do not get those repaired as soon as possible. So you just look for ability to hear. They might get tinnitus, oozing from the ears and the like. I talked about cardiovascular already, and we've already seen that our patient had shock. So that could be from arrhythmias, but also the direct bleeding. Then in the GI, anyone who complains about abdominal pain, even when they are not vomiting or diureting or having bloody stools, please, they need to be kept, because that's an impending GI emergency with peritonitis and likely ruptured colon. And more in the neurological with head injury. We also see more things like the bilateral amputations, skin, the burns that we've already talked about. Can go on, Jimmy. That we've already talked about. And then more things to do with, subcutaneous emphysema from the respiratory rupture, either skin involvement or direct lung involvement, giving you air under the skin. And that can spread as high as your neck and obstruct the patient's neck. So it's very, very important to know what to expect. And the patient can easily have each of these, okay? Because we've said it's a multi-system involvement. So what do we do for these patients? We want to use ATLS, ITLS, pre-hospital ATLS. There are very many guidelines in there, but the principles are the same. And we want to plan for a multi-casualty major incident, let's say, or a disaster for that matter, because it could easily exceed your resources. We've put a lot of emphasis on safety. So scene and personal safety. You do not know what exploded. Let's say it's a gun, you're hearing gunshots, please do not approach unless the people that are well-dressed and have the proper tools to stop the person that's shooting can come and assess the scene and let you in. If it's an explosive area, the same thing, it's a red zone. So do not go to the red zone, wait, and they bring you the patients to the green zone where you're safe enough. But also wear the actual PPE, okay? Where these might have funny toxins all over the place. So you could require respirators, you could require headgear, an actual CBAN kind of PPE level. So depending on the type of explosive, you might require advanced or more. But also beware that, and this was again hinted on, that our patient was known to be a good person at detonating these things. So wherever he was, he probably knew what it was. But for us as civilians, we might not know this. So beware of secondary devices. If you go in, something might go off and you end up being a casualty yourself. So be ready to take note of those things. But also, as we receive these patients, they might be the ones carrying the things. They might be the terrorists themselves, okay? You have very little to do about that, but be observant. Be observant and notify the rightful authorities if these patients turn out to look to you. Be suspicious, okay? Have a high level of suspicion and a high clinical acumen, whatever you're about to find out. Activate your incident command system via your ED and make sure you have everything ready. If you don't have enough space, make sure your ED outside. Maybe you have a tent or a parking lot, use it for your triage. Make sure all your patients are triaged appropriately. There's a very high chance that they might be over-triaged. Those that are minor might come in as red, and beware that you might receive two kinds of disasters. Those that are very many and not injured, and those that are very sick, yet few, Okay, and so you just be open-minded and flexible and adaptable to the situation. So this is our primary survey. I think, Anna, we can move on. That has been highlighted a lot. Secondary survey has also been highlighted, but the special considerations. These patients often have hidden injuries, so reassess them frequently. For our patient, they were reassessing every 5 minutes. So because they were load and go from the pre-hospital, even the pre-hospital team will be reassessing continuously. So when you take over in the ED, continue that reassessment, hook them to a monitor, make sure they're being reassessed every 5 minutes. And then take care of those multiple injuries. They could have both penetrating, blunt, burns. It could be really a mixed pattern. So have a team that's able to manage all those things. And the most urgent things we want to carry out in our ED, as per our ITLS, ATLS algorithms, we want to secure this patient's airway as soon as possible, our patient. And I think they didn't do that on scene. They did it when they transferred. Most times this is time taking. So even for the pre-hospital team, unless you're super skilled at doing that, this and the next one, the needle decompression and bleeding control, are the 3 things that are acceptable to delay pre-hospital transportation, because then the patient will not arrive. So if you have the skills, do them pre-hospital. If you do not, take them to a controlled environment in your resuscitation bed and make sure you secure the airway before it dies out. Dexamethasone was given in our patient. However, just recent studies showed no benefit, no mortality benefit. It might actually make our patients worse because it will drop their immune system, yet you need it actively to fight for them. So probably not very useful in someone who is acutely injured. And then control bleeding, whatever way you can, appropriate antidotes depending on what your patients were exposed to. So all the first 5, actually 6, can be done in your resuscitation bay, in your ED. Tranexamic acid can be given within 3 hours. Beyond 3 hours, there is no role. Okay? So give it 1 gram, give it as a bolus, and then start your maintenance of 8 hourly, 500 milligrams. What is permissive hypotension? This only if you don't have head injury. So if you already have signs of increased intracranial pressure or signs of head injury, please do not do permissive hypotension. And by this, we normally mean that you're trying to resuscitate only as far as having your patient's level of consciousness, signs of shock, your MAP, just about 60, okay, 65. Anything above that, or a systolic of 80, 90, anything above that will cause the patient to bleed further, especially in blunt injury. So patients that don't have head injury, we accept that and then give them antibiotics. The best is the cefazolin and cephalexin, but I don't think we have that in our public hospitals. So I added ceftriaxone in there, and gentamicin has been proven to work. Then augmentin might be more available than cephalexin and cefazolin. So if you have it, give it. And then consult your surgical team. They will do damage control surgery. Usually it's done just to arrest bleeding, nothing more, not to correct anything, just to stop bleeding and further injury. And so hemostasis and keep preventing any further bleeding. And for specific management for gunshot wounds, we want to give the antibiotics within the first 24 hours. I've already highlighted that. Now, that's for usually uncomplicated civilian extremities. You can give short courses. But for our people that are in Mogadishu, because those injuries are usually bigger, they're more extensive. So they'll have limb injuries like our patient, probably needed at least 10 days of antibiotics. So what our role is to start, okay? Not to necessarily continue, because that patient will be in ICU somewhere and they'll have to continue that. And these injuries, as you're consulting the surgical team, you're notifying them that this patient needs to arrest bleeding, but any corrective things will be done in 48 to 72 hours. So that's part of your disposition, because you should know why you're calling them. And then these patients often need a multi-phase CT angiography just to make sure there is no penetrating vascular injury, and that can be done now in most of our settings because we have CT scans. For blast injuries, MCI has been, but for lung, we need to ventilate this patient as if they have ARDS. So we just need to protect their lungs. We talked about barrel trauma, okay, and the likelihood of that air expanding in their lungs. So if you give them a lot of bagging, you're pushing hard, you think you're giving oxygen, but you're causing further injury. So just do adequate pressures, whether you're mechanically ventilating for those that can, and those that are using BVM, just do slow inflations, not super aggressive inflations. Have your protocols for the public health side. Just make sure you have your drills, make sure you have your protocols ready, your incident command system is ready to go if such a thing happens. And as we conclude, these are investigations in addition to the labs that we normally do, RFTs, LFTs, these are things that are must do because they will help you identify the site of injury, while the others are going to help you just know the state of your patient, their kidneys. If they've had rhabdomyolysis from these crushed legs, like the ones we saw in the image, how are they doing with their kidneys? How much should I give, and the like. However, take note of the red ones. Having normal imaging is not equal to being safe because we've said some of these things can delay, okay? You can have lung showing, actually lung contusions show up sometimes 6 hours later. So you doing it immediately might be deceptive. So you have to monitor and keep that patient. And then avoid MRIs because of those metallic fragments. Disposition, we would have to think about the operating theater, especially if they're unstable, if they have signs of peritonitis, or if they need if they have a bad tamponade from those injuries and they may need a thoracotomy. And then ICU, all patients that have blast lung or polytrauma have to go to ICU, and we observe everyone else if they don't have those things for at least 24 hours to 48 hours before we discharge them. Make sure you document appropriately because this can easily be a legal case, okay? If what you've not written has not been done. So if you're saying you've seen 2 exit wounds, 3 wounds, and it's not there in your chart, in the patient's chart, no one can prove it. So document, take pictures, or draw as much as you can. And finally, the red flags are on that slide. Someone, I think, asked that in the chat. Think about significant burns, upper airway burns, air embolism, which is suspect, especially difficulty in breathing after a blast, radiation, shrapnel. So literally all the things we've discussed. Yeah, those are just examples of images. Those are shrapnels, the bullet wounds in the abdomen, then your lung contusions, bat wing sign, and then that's a ruptured tympanic membrane that was later repaired. I think that's it. So in the pearls and pitfalls, it's very important for us to control that external bleeding. We've had tourniquets, we've had deep wound packing, we've had direct pressure. Each one of us has a role to play. The first is always direct pressure. Only apply the tourniquet if you do not arrest the bleeding with the first two, the direct pressure and the deep wound packing. And always think about the mechanism because that will help you predict where your injuries are. Reassess every 5 to 10 minutes. Use blood early. These patients are losing blood, not just water. So give them the blood. And I'm happy to hear that our patient got a massive transfusion protocol activated. That's not easy for us in the usual public service setting because we don't have fresh frozen plasma, but if you order these things and put pressure on the right places, you can always have them. And then always suspect hidden injuries. And the vice versa is true for the other. Right. Thank you very much.
Thank you very much, Dr. Krista. That was very elaborate. And I think everyone is happy. When I said the presentation was gumite. Yeah, so it was a good one. So well done, everyone. Unfortunately, Major has gone. He wanted to attempt some of the questions, but he has responded to most of the questions in the chat. And the people who asked them responded that they were happy with the responses. So for now, I do not have any unattempted question in the chat. I think I'll just move to even the expectations were met. Actually, there is none that has not been attempted to. So I think we did a good job during the presentation. Thank you to the expert panel that we had. At this point, we have 2 minutes left to the end of our session. I would love to go through the poll questions. And we go through it, and then shortly, as they are casting the poll questions, I would love to ask our panel, within 5 seconds, can you tell us the take home? These people are just from talking, so I'll start from Andrew. Yes, please give us a take home in 5 seconds. If you were to tell someone about ballistic injuries, what would you tell them in 5 seconds?
It's hard to say it in 5 seconds, but what I will just say is emergency care is time sensitive. Do it fast, you will save a life.
Okay, Dr. Paul.
In case you are attending to a patient, a casualty from a ballistic incident, safety to yourself, safety of the situation, and safety of the area and safety of the patient are very important. So always consider yourself first before you think about even the patient. Not rushing, because you'll get injured too. Thank you.
I'll go with Lieutenant first.
Thank you. I want to say that ballistic injuries come fast, but their impacts go slow. So save the life, but never forget about the effects of the injury.
Okay, Dr. Priska.
Ballistic and blast wounds, injuries cause polytrauma and multiple casualties. So be ready for either, because they're quite lethal.
Okay, thank you, everyone. My take-home message is from Afande. He said, basic things save lives.
Yes.
Okay, so our poll questions. Question 1 was from the history and the primary survey. What were the eminent emergencies in this patient? And majority of us got it right. It was airway obstruction, tension pneumothorax, and hemorrhagic shock. And then question 2 was, what are the emergency life-saving interventions for this patient? Equally, 93% of us got it right. It was advanced airway, needle decompression, tourniquet application, and blood transfusion. The third question was, what are the possible differentials that would one choose and the rationale? And again, 87% of us got it right. We said blast lung injuries, tympanic membrane rupture, bilateral lower limb amputation, blunt abdominal trauma, and mild TBI. The last question was, what were the priority investigations? This one, 75% of us got it right, and that was EFAS, blood grouping, brain CT scan, and random blood sugar. Thank you all for attempting. I can see that we are learning great from these sessions. Okay, so for the last part of our echo session, we are going to take screenshots. So as usual, we all turn on our videos, give your best smile, and then we take the video.
Priska.
There's a Priska.
Hey, Priska is there. EMS echo.
How many screens there is?
6 screens.
Another fun area.
Should be more condition.
That's nice. Yes. You guys invited them.
All right.
Okay, thank you everyone for logging in. From us here to you. Bye. See you next time.